Hello everyone, I am Pavani, Optometrist. Today my topic is about Neuromyelitis Optica and what is the main optometrist role in this condition. Neuromyelitis Optica is a rare autoimmune demyelinating disorder which affects the optic nerve, spinal cord, which is mediated by the AQP4 antibodies. So when we talk about the aquaporins, these are the special water channels which are present in many tissues of the body including eye. So the main function of these aquaporins are it regulates the water movement across the cell membranes and it helps in maintaining the hydration, transparency and pressure balance in the ocular tissues. As we have different types of aquaporin channels in eye like in cornea, lens, ciliary body, retina and lacrimal gland. In cornea, we have the AQP1, AQP3 and AQP5 aquaporin channels which helps in and epithelial cell hydration. And in lens, we have AQPO and AQP1 aquaporin channels which helps in maintaining the lens clarity and water transport. And in ciliary body we have AQP1 and AQP4 aquaporin channels which helps in aqueous humor secretion and IOP regulation. In retina we have AQP1 and AQP4 water channels which helps in maintaining the water balance. And in lacrimal gland we have AQP5 which helps in maintaining the tear secretion and dry eye protection. Normally, these aquaporins are normal proteins, but in some autoimmune diseases, the body produces antibodies against them, which leads to the damage. So, aquaporins are like doors which lets the water in and out of the cell. So, when there is autoimmune disease and when antibodies produce, these attack and destroy the doors, so the system collapses. Coming to the etiology, it is autoimmune origin where antibodies are produced against aquaporin for water channels in astrocytes. These astrocytes are the type of glial cells which are supporting cells present in the central nervous system which is star shaped. That's why we call it as astrocyte cells which support the neurons and maintain the environment around them. These are mainly found in the brain, spinal cord, optic nerve and retina. So, the main function of these astrocytes is they express the AQP4 channels which is mainly helpful for the central nervous system and it helps in maintaining the water movement and regulate the potassium around neurons. And in retina, we call it as the Mueller cells which is functionally similar to the astrocytes and express AQP4 channels. That's the reason why when these AQP4 channels get disturbed, retina too get disturbed. And when it comes to eye, it is present in the optic nerve head which is rich in astrocytes with AQP4 water channels which are crucial for the fluid balance around ganglionic cell axons. And in retina, these astrocytes and Mueller cells line blood vessel and helps in regulating the water, ions and neuronal health. In ciliary body, there are few or no astrocytes present. That's the reason why the ciliary body is not affected and it doesn't lead to glaucoma in case of NMO case. And so when there is a NMO, these AQP4 IgG antibodies bind to AQP4 water channels on astrocytes. This activates the complement cascade which leads to astrocyte destruction and causes secondary damage which leads to oligodendrocyte loss, demyelination and neuronal death. And when it comes to optic nerve, it leads to optic neuritis and retinal ganglionic cell death. The main trigger factors for this is infection, stress, vaccination and genetic predisposition. It may not be hereditary, but as autoimmune diseases are hereditary, there is a tendency that may run in the families. And coming to the ocular signs and symptoms, there will be a sudden severe loss of vision, mostly bilateral, and patient complains of pain on eye movements, blurred or dim vision, loss of color vision, visual field loss. Pain occurs due to the optic nerve is surrounded by a sheath which we call it as the meninges, which is covered with three protective layers. The outer layer is called the dura mater, middle layer is arconide and the inner layer is called the pia mater. So the pain fibers which we call it as the nociceptive fibers, these are carried by the ophthalmic branch of the trigeminal nerve and these fibers are present in the outer layer. So when there is an inflammation in the optic nerve in the dura mater, the trigeminal pain fibers will get activated. As a result, the patient complains of pain while moving his eyes. And sudden vision loss is due to antibodies rapidly destroys the astrocytes in the optic nerve through inflammation which leads to edema and there will be a conduction block, that means signal doesn't pass properly to the brain, which leads to irreversible axonal death. As a result, it leads to the central field loss. And coming to the signs, there will be a decrease in visual acuity, color vision defect, reduce in contrast sensitivity, RAPD, and in fundus it shows the optic disc edema. Sometimes it may be absent, and in OCT it shows the retinal nerve fiber layer thinness and visual field defects, which is mostly central altitudinal diffuse defect. And when it comes to systemic diseases, there will be a weakness and paralysis of the limb, numbness, sensory loss, bladder and bowel dysfunction, and persistent hiccups, nausea and vomiting. Coming to the investigations related to eye, first we need to rule out the visual acuity, which shows the severe vision loss, which may even lead to no perception of light, and color vision defect, which shows mostly red and green color vision defect initially. So this is the first most sign of the neuromyelitis optica. So initially the person shows the red and green color vision defect even before the vision loss. Then later it may lead to vision loss, and there will be a reduced in the contrast sensitivity, and pupils also show the RAPD. And when it comes to the visual field, there will be a central scotoma, and in fundus it shows the disc edema. In OCT it shows the retinal nerve fiber layer thinning, and in VEP it shows delayed latency and decreased amplitude. MRI shows the bilateral optic nerve lesions, long spinal cord lesion, which is different from the multiple sclerosis, and in serology it shows AQP4 IgG positive in 70% of the cases and MOG IgG in some cases. So coming to the differential diagnosis, in multiple sclerosis, it shows the mild optic neuritis, which is mostly unilateral, and there will be a partial recovery. But when it comes to the neuromyelitis optica, it will be bilateral. And MRI in a multiple sclerosis, even MRI shows multiple white matter lesions, which is different from neuromyelitis optica. And another differential diagnosis is ischemic optic neuritis, which shows a sudden painless vision loss, whereas in NMO, it shows the painful vision loss. Of course, the disc swelling is quite common in both the cases. And in another differential diagnosis is toxic nutritional optic neuritis, which shows symmetrical progressive vision loss with bilateral disc pallor. And in glaucoma, another most differential diagnosis is glaucoma. In glaucoma, it shows the peripheral field loss, which leads to central, but in this case first there will be a central field loss, which may lead to peripheral in severe cases. Coming to the management, high dose IV corticosteroids will be given, and even plasma exchange is done if there is no response. Intravenous immunoglobulins, and mostly the ophthalmologists usually co-manage with the neurologist. NSAIDs and steroids will be given for severe pain, and if there is a vision loss, low vision aids and rehabilitation will be done by the optometrist, and the counseling will be done for this, as there will be a central scotoma and color vision defect in mild cases. So when we talk about the optometrist role, when the patient complains of sudden bilateral vision loss, the first thing we need to do is, the first obviously we'll go for the visual acuity assessment. Later you need to rule out the color vision defect. This is because that is the main key factor to differentiate between the multiple sclerosis and other optic neuritic cases with NMO. So if there is a red and green color vision defect, so that is the key point of the NMO. And there will be a reduction in the central contrast sensitivity, visual acuity, and visual field shows the central scotoma, and pupil shows the RAPD. In OCT there will be a retinal nerve fiber layer thinning, and there will be a sudden bilateral vision loss, but in case of multiple sclerosis it is different, and here painful vision loss. And when you detect and even in VEP it shows the delayed latency. So whenever you get the patient with these signs, we need to refer to neurologist or neuro-ophthalmologist for further evaluation, because it may lead to vision loss, so we need to refer them urgently. So after treatment we may prescribe the low vision devices or rehabilitation for the patient to lead the independent life. We also need to give counseling, because there will be a color vision defect and central scotoma. We need to give the clear counseling how to lead his life independently. If you find this video helpful, please subscribe.